Welcome. Today we're going to examine the cannabinoid type 2 receptor in the field of psychiatry. So let's get started. Historically, CB2 receptors have been classified strictly as peripheral immune receptors, but modern neuroscience has mapped functions to neurons and glial cells within key brain circuits. We will explore how CB2 regulation and modulation offers a novel, non-psychoactive therapeutic target for a full spectrum of psychiatric conditions, and I will elaborate on the mechanisms of action that can deliver a huge potential. So my specialty is family medicine, which has allowed me to be involved with many behavioral disorders over the past 48 years. And of course, my military background has created a great deal of interest in wartime trauma, amputations, PTSD, and suicides. And in the interest of full disclosure, I distribute beta-caryophylline worldwide through my company, Blair Medical Group. So this is a critical foundation slide. Understanding the different locations and the functions of cannabinoid receptors is essential for appreciating why CB2 receptor is such a promising target. So let's take a walk through the key distinctions. Not to confuse you, but in my talk, I will be referring to CB2 receptors as CB2 interchangeably. Now, CB1 receptors are found primarily in the CNS with high density in brain areas responsible for cognition, memory, movement, and pain perception. These mediate most psychiatric and psychotropic effects within the cannabinoids, the intoxication that people associate with cannabis. But CB1 activation can lead to memory impairment and addiction potential. CB2 receptors predominantly found in peripheral immune cells, but importantly also expressed in the brain by microglia, astrocytes, and neurons. The critical advantage is that CB2 is a non-psychotropic, meaning that it doesn't cause euphoria or intoxication or the adverse CNS effects of CB1 agonists. Instead, CB2 modulates the key neurotransmitters and immune responses with anti-inflammatory and analgesic properties, making it promising therapeutic target for neuroinflammation, chronic pain, and psychiatric disorders without CNS side effects. Now let's focus specifically on why CB2 represents a breakthrough for psychiatry. CB2 is notably expressed in the various critical brain regions such as the prefrontal cortex, amygdala, hippocampus, and striatum, indicating its potential role in modulating mood, memory, and reward mechanisms that play into psychiatric conditions. I want to emphasize the key advantage of CB2 as a lack of intoxicating effects and activity compared to CB1 agonists. This means that the therapeutic potential without euphoria or addiction liability. This is fundamentally different from earlier cannabis-based approaches. The fact that it is expressed in regions critical for anxiety, depression, and schizophrenia make it uniquely positioned to address multiple psychiatric conditions simultaneously. So that CB2 was traditionally considered a peripheral immune receptor, but is now identified in brain tissues, particularly in key psychiatric areas. It's expressed in neurons, microglia, astrocytes, and in different regions, with the most significant discovery for psychiatry being the presence of CB2s in the limbic system. Expression levels are generally lower than CB1 receptors under basal conditions, but are dramatically upregulated during inflammation or chronic stress, acting as an on-demand protective system. CB2 is found in these important brain centers: the amygdala, the critical center for emotional processing and fear responses; the hippocampus, vital for memory consolidation, emotional content, and neurogenesis; the prefrontal cortex, regulates executive function and top-down emotional control. This localization allows CB2 to directly modulate anxiety, stress resilience, and emotional memory extinction. So what happens during disease and aging? The CB2 receptor isn't just passively present, it's dynamically regulated. For inflammatory context, transient downregulation in microglia occurs under lipopolysaccharide influence, upregulated during interferon resolution phase. And during neurodegeneration, expression is increased in plaque-associated microglia in Alzheimer's disease. And there are sex differences where the female specific effects on synaptic architecture and social memory. And as we get older, age-dependent CB2 receptors increase, showing a specific effect on microglial aging. Now, CB2 expression is naturally low in the healthy young brain, but increases significantly with age. This is thought to be a compensatory response to the cumulative inflammatory load on the CNS. In older brains, microglia become primed. They are more sensitive to inflammatory stimuli and lower to return to a homeostatic state. CB2 receptors acts as a brake for this hypersensitivity. Furthermore, CB2 agonists enhance the degradation of toxic proteins like amyloid beta and alpha-synuclein by promoting microglial autophagy. New data suggests that CB2 modulation skews aged microglia towards a wound healing phenotype, increasing their ability to repair blood-brain barrier and clear cellular debris without releasing neurotoxic cytokines. Thus, increased CB2 in aging is not necessarily to turn off the immune system, but to promote microglial homeostasis. Let's talk about CB2 and neuroinflammation. Psychiatric disorders are increasingly associated with chronic inflammatory and glial activation. Both microglia and astrocytes as central pathogenic factors. CB2 connects the immune system and the brain circuits regulating mood and cognition, ultimately preventing neurodegeneration. CB2's role promotes a shift from the pro-inflammatory M1 phase to the anti-inflammatory M2 phase and phenotype, reducing IL-1 beta, tumor necrosis factor alpha, and IL-6, the key inflammatory cytokines implicated in psychiatric disease. CB2 actually connects the immune system to the brain systems, regulating mood, memory, and cognition. Furthermore, it promotes neuronal survival and safeguards the brain against inflammation, toxins, infection, and trauma. By doing so, CB2 supports learning and memory formation by the modulation of synaptic plasticity, which is crucial for cognitive function. Now, in psychiatric disorders are increasingly linked to chronic neuroinflammation and microglial activation, and it's central to this process. CB2 anti-inflammatory role. CB2 regulates the microglial activation and polarization, as I mentioned before. It promotes a shift from the pro-inflammatory to the anti-inflammatory phenotype, while reducing the production of pro-inflammatory cytokines and actually instituting anti-inflammatory cytokines like IL-4. In addition, CB2 connects the immune system and brain circuit, regulating mood and cognition, because we now know that inflammation reduces neuroplasticity and promotes neurodegeneration. Thus, neuroinflammation is highly prevalent in psychiatric disorders. This process is distinct from peripheral inflammation and is a key driver of the pathology of many psychiatric conditions, influencing brain function and behavior. It starts with microglial activation, extends to cytokine dysregulation, and applies to a wide variety of disorders, including anxiety, depression, schizophrenia, bipolar disorder, and autism. And it contributes highly to their highly variable symptoms. Now let's look at some of the mechanisms that are involved. This is a cornerstone slide that outlines the molecular pathways that are involved in CB2 protective cascades. NLRP3 inflammasome. This is the CB2 suppression of inflammation components. It promotes autophagy, it modulates degradation, and it reduces IL-1 beta, TNF alpha, and IL-6 cytokines. Nuclear receptors. CB2 inhibits nucleic factor kappa beta signaling. This reduces pro-inflammatory cytokine production throughout the brain, but activates uh, NRF2 as a nuclear transcription factor that plays a critical role in the cellular defense against oxidative stress and inflammation. It mediates neurotrophic factors. So CB2 restores BDNF, brain-derived neurotrophic factor, SIRT1, and PGC1 alpha expression, supporting neuronal survival and synaptic plasticity. Why are these important? BDNF is a protein that plays a crucial role in development, maintenance, and function of neurons. It's essential for neuroplasticity, which is the brain's ability to adapt and reorganize itself. CRT1 is a sirtuin, which modifies proteins by removing acetyl groups that regulate transcription factors, enzymes, and proteins, including blocking pro-inflammatory pathways. And PGC1 alpha is a PPAR gamma coactivator alpha, is a master regulator of various metabolic processes, particularly those related to mitochondrial biogenesis, oxidative metabolism, and thermogenesis. I think of these factors as making CB2 signaling cascades quite extraordinary. In addition, you have the glial function. CB2 regulates microglia and astrocytes. It corrects for oxidative stress, and it includes synaptic transmission promotion. So besides drugs, what other alternative therapies have been shown to modulate neural inflammatory disorders? In this case, we have to explore the ketogenic diet that is a result of high fat and a very low carbohydrate food choices. Ketones, mainly in the form of beta-hydroxybutyrate, are generated by the liver and inhibit powerful neuroinflammatory cytokines, TNF alpha. These have been previously shown to be universal inflammatory cytokines stimulating neural disruption. The result clearly shows that decreased neuroinflammation on this diet with optimized mitochondrial function and improved cognitive clarity. So in the upper left-hand corner, we talk about the ketogenic diet and modulating that particular dietary pattern. And below that, we talk about the production of ketone bodies that the liver generates as a result of a reduced supply of glucose. The body has an infinite supply of ketone bodies in the generation from lipolysis and fat. And in the section 3, we have a reduction of pro-inflammatory cytokines. Ketones inhibit the cytokine signaling very specifically. We show that there is definite improvements in blocking TNF alpha, IL-1 beta, NFK kappa beta, and this leads to neuroprotective brain outcomes with decreased neuroinflammation, optimized mitochondrial function, and improved cognitive clarity. So what conditions have been shown benefits from an anti-inflammatory ketogenic diet? Here are 9, but almost all have been showing some improvements in small studies. The ketogenic diet holds a promise as a therapeutic option for various neurologic diseases characterized by neuroinflammation. Its ability to modulate inflammatory pathways and improve metabolic states in the brain provides compelling avenue for research and clinical application. Well, how does this relate to CB2 activation? First, there is no direct connection, but research suggests that a ketogenic diet may prime the environment to a more receptive one to CB2 agonists, or even indirectly increase the First, there is no direct connection, but research suggests that a ketogenic state may prime the environment for a more receptive to CB2 agonists, or even indirectly increase the expression of these receptors on microglia to dampen neuroinflammation. Both the ECS and the ketones deal with bioactive lipid signaling, shifting the body's lipid profile, which can alter the availability of endogenous cannabinoids like 2-AG and anandamide that naturally bind to CB2 receptors. When combined, ketosis provides the metabolic fuel or ketones that allows for CB2 stimulated microglia to perform repair heavy tasks like neurogenesis and synaptic pruning more effectively than they could in a glucose-heavy and high inflammatory environment. Finally, ketogenic metabolites often interact with shared targets like PPAR receptors and the GPR55, which I will discuss shortly. So, what kind of evidence do we have that CB2 agonists work in psychiatric disorders? Well, there is robust preclinical data demonstrating that CB2's benefits. Animal studies show a significant efficacy across various psychiatric disorders, models without psychogenic and psychotropic side effects. So, what's the potential in humans? In preliminary human studies, schizophrenia there's a lower expression of CB2 receptors, and this is linked to increased schizophrenic risk. A CB2 positive allosteric modulator, a PAM, reverses amphetamine-induced hyperlocomotion and blocks psychosis-like behaviors, a model for schizophrenia, and PTSD and trauma. So CB2 signaling modulates fear extinction and emotional memory processing, offering a potential therapeutic avenues for trauma-related disorders like PTSD by enhancing stress resilience. And cognitive dysfunction. CB2 activation has been shown to improve cognitive deficits, including memory and executive function, which are often impaired in various psychiatric conditions. So, how does CB2 activation help anxiety? In numerous studies, CB2 activation reduced anxiety-like behaviors in chronic stress models. Taking a immunomodulatory approach, natural CB2 agonist beta-caryophylline has shown anxiolytic properties through anti-inflammatory and antioxidative mechanisms supporting the anti-anxiety reduction. From a genetic standpoint, an interaction avenue, CB2 gene polymorphisms interact with environmental stressors with adverse genotropic environment, increasing depression and anxiety risk, suggesting CB2's role in stress resilience on a genetic level. And network effects. CB2 reduces microglial activation in hippocampal regions and improves emotional regulation through neuroinflammatory reduction. See, there are all positive benefits in anxiety elimination. And what about depression and CB2 receptors? Depression will likely be the largest expected contributor to disease burden by 2030. Depression is characterized by widespread neuroinflammation, and this is where CB2 intervention becomes crucial. So let me explain what activation of CB2 receptors can do. Number one, it increases hippocampal BDNF expression. It reduces hippocampal neuroinflammation. And there's good evidence that adverse child events, or ACE, as early life stresses, reduce CB2 receptors, whereas CB2 enhancement can reverse these depressive behaviors. So what are the critical implications? CB2 agonists can reduce depressive-like behaviors in animal models with comparable efficacy or better than conventional antidepressants. This translates into potential human treatments targeting neuroinflammation versus SSRIs. This could lead to faster acting antidepressants that work within days as opposed to many weeks, and it offers new hopes for patients with treatment-resistant depression. So naturally, my military experience has inclined me to consider PTSD in particular. Research points to a bidirectional relationship between post-traumatic stress disorder and neuroinflammation. While PTSD has traditionally been viewed through a psychiatric or a neurobiological lens, focusing on the HPA axis and amygdala, recent clinical and preclinical data suggests that inflammation signaling is a core component of this pathophysiology. So the key mechanisms of neuroinflammation in PTSD. Now, one is a chronic stress or a trauma that can prime microglia, shifting them from a resting or surveillance state to a pro-inflammatory state. Number two is a stress-related cell damage releases damage-associated molecular patterns, or DAMPs, which bind to toll-like receptors on glial cells, triggering the release of inflammatory cascades. Individuals with PTSD show pro-inflammatory cytokine elevations, and both in peripheral blood and in some cases cerebral spinal fluid. And then there's the blood-brain barrier integrity disruption. Persistent systemic inflammation can weaken the blood-brain barrier, allowing peripheral immune cells and cytokines to infiltrate within the CNS. So what are the clinical implications? Elevated C-reactive protein and other markers prior to trauma predispose individuals to developing PTSD, while elevated cytokines interfere with the synaptic plasticity and neurogenesis, leading to anxiety, hypervigilance, sleep disturbances, and cognitive and memory dysfunction. In fact, these processes can create a two-way cycle to worsen trauma stress. Furthermore, chronic inflammation in PTSD is linked to higher risk of cardiovascular disease and autoimmune disorders. Thus, using the anti-inflammatory agents or specialized bioactive lipids could provide a new therapeutic avenues for patients in place of traditional SSRIs or psychotherapy, or for those who do not respond. So how does this relate to CB2 receptors? Well, unlike CB1 receptors, CB2s are expressed predominantly on microglia and astrocytes that support neuron and the blood-brain barrier. This is a crucial distinction for clinical practice. By targeting CB2, we can influence neurobiology without the cognitive impairment or intoxicating associated with CB1. In part one, we see that the target for microglial activation, for which CB2 modulates, by modulating epinephrine and cortisol release from the adrenals and glutamate from the limbic system, the prefrontal cortex, hippocampus, and amygdala. In part two, in the upper right, we demonstrate the master switch in downregulating neuroinflammation. When a selective CB2 agonist binds to the receptor on a primed microglial cell, it inhibits the production of pro-inflammatory cytokines like tumor necrosis factor, which are all the same markers that we see elevated in chronic PTSD patients. Simultaneously, CB2 actually activates and promotes an anti-inflammatory resolving phenotype that is neuroprotective and facilitates cellular repair. So, what are the therapeutic impacts and clinical outcomes? Synaptic protection. By reducing neurotoxicity and oxidative stress, we preserve the synaptic plasticity. This is essential for patients undergoing cognitive behavioral therapy, as they need to function synaptic connections to relearn safety. Hippocampal support. Neuroinflammation is a known inhibitor of neurogenesis. By resolving the inflammatory cycle, CB2 signaling supports the recovery of hippocampal volume, which is often distinguished in long-term PTSD. And fear extinction. On a behavioral level, this translates into improved fear extinction and a reduction in the hyperarousal state. We're also essentially cooling down the overactive amygdala by calming the underlying neuroinflammatory fire. So bottom line, if CB1 is for acute symptom management, CB2 is for long-term neural resolution. For a clinician, the therapeutic advantage is clear. A non-intoxicating, immune-focused approach to a complex physiologic disorder. So the evidence surrounding CB2's involvement with schizophrenia is remarkable, but it's almost totally unexplored. Lower CB2 expression is linked to increased schizophrenic risk, with altered CB2 levels found in the first episode of psychosis. CB2 activation induces several antipsychotic-like effects. It reverses amphetamine-induced hyperlocomotion, and amphetamines are stimulant drugs that increase the release of neurotransmitters, particularly dopamine in the brain. This increase can lead to hyperlocomotion. An elevated level of activity or restlessness, increased motor activity, and euphoria and exaggerated movements believed to be hyperactive in individuals with schizophrenia. Now, CB2 blocks MK801. This is a drug that induces psychosis-like behaviors by inhibiting glutamate excitotoxicity, but promoting dopamine. And it demonstrates efficacy in pre-pulse inhibition a deficit model in individuals with schizophrenia typically show reduced PPI reflecting disrupted sensory signaling. What are the mechanisms involved? Well, CB2 regulates dopaminergic and glutaminergic neurotransmission. It suppresses microglial activation, reducing neuroinflammation, and it supports synaptic plasticity and neuroplastic changes, inducing neurogenesis and neuritogenesis. Ultimately, there is the neuroinflammatory link. Schizophrenia involves elevated inflammatory markers. CB2 activation reduces the neuroinflammation and supports cognition and addresses the root cause of the disorder. Now let's switch to consider suicide and the neuropathology associated. Here we know that from the post-mortem studies that altered CB2 receptor patterns are detected in the prefrontal cortex and amygdala of suicide victims, brain regions critical for emotional regulation and decision-making. There is a protein dysregulation, altered cytoskeletal proteins that I list here. Changes are observed alongside CB2 alterations, and these mechanisms are engaged. It elevates pro-inflammatory signaling, and redox system alterations suggest that impaired CB2 function can contribute to suicidal vulnerability through neuroinflammatory and oxidative stress. Finally, there's gene expression. Downregulated cytokine signaling combined with upregulated glutamineric signaling creates a neurochemical environment conducive to suicide ideation. But there's more. This slide represents a detailed data on the molecular alterations observed in suicidal victims. Clearly, we see a complex objective pathology at cellular, immune, metabolic, and genetic levels with potential modulation by enhanced presence of CB2 receptors. When we look at the CB2, we need to shift our perspective from simple signal transduction to specific and long-term epigenetic modulation. We aren't just dampening a temporary flare-up. We are actually intervening in the way the cell's instruction manual is read and transcribed. Constant stress primes the microglia through DNA methylation and histone modulation, locking them into a permanent pro-inflammatory state. CB2 activation is our tool for reversing that lock. Postmortem brain studies in suicide victims reveal CB2 expression finding. Gene expression is altered significantly in the limbic areas of the brain. In addition, there are associated protein changes and finally, there are molecular mechanisms that are dysregulated. This leads to the therapeutic implications that CB2 modulation may restore altered expression patterns at risk individuals. A biomarker potential CB2 receptors and associated proteins could identify increased suicidal risk. And targeting endocannabinoid system dysfunction may prevent progression to suicidal behaviors. In short, we aren't just treating symptoms, we are using the CB2 receptor to facilitate deep genetic reset of the neuroimmune system. So I want to introduce a groundbreaking discovery. The GPR55 is often referred to as a potential cannabinoid type 3 receptor due to its interactions with the other cannabinoids. While it shares some of the characteristics with traditional cannabinoid receptors, it has distinct functions and binding profiles. We know that it's involved with pain sensation, inflammation, and bone density regulation, suggesting a broad potential influence beyond the classical cannabinoid effects. Heteromeric receptors occur when different receptor subsets come together, like CB2 receptors and GPR55. The intersection between the different receptor components can alter ligand binding and signaling pathways. The new receptors can exhibit unique properties, leading to various cellular responses. For instance, they can trigger distinct signaling cascades compared to their monomeric counterparts. In suicide victim, reduced GPR55 gene expression is found in the dorsolateral prefrontal cortex, whereas CB2 receptors are abundant. It turns out that CB2 forms a heteromere complex with GPR55, forming a separate and distinct receptor complex. This creates a unique positive modulator of synaptic activity and microglial responses. When a CB2 or GPR55 receptor ligand connects with this heteromere, it activates both CB2 and GPR55 pathways, including cascade effects on immune, metabolic, microRNA, and epigenetic systems, hence the concept of the CB2 GPR55 axis. In a rodent suicide model, GPR55 agonists reverse depression and suicidal threatening behaviors, as well as the neuroinflammatory markers. Thus, the CB2 GPR55 heteromere could activate by the CB2 receptor to prevent these self-destructive impulses. What's the clinical significance of this finding? CB2 GPR55 axis modulation is a novel anti-suicidal strategy for at-risk populations. This finding could revolutionize how we approach suicide prevention, moving from symptom management to addressing the underlying neuroinflammatory conditions specifically. So this is a compelling case that demonstrates the therapeutic potential of a CB2 activator. So this is a 64-year-old man who suffered multiple fractures, degloving, and foot trauma from a motorcycle accident 41 years ago. He developed fleeting intermittent stabbing pain initially, which progressed to constant pain in 2022. Despite treatment with opioids, gabapentin, and SSRIs, standard approaches for the neuropathic pain and the depression he found to no avail. He was suffering from phantom limb pain. Cannabis he was using 6 to 12 joints a day. It helped, but it led to depression and suicidal ideation as a result. 2 years ago, he began taking BC Plus or beta-caryophylline 30 milligrams twice a day. After just 2 weeks, he noted significant improvement, and at 6 weeks, he was generally pain-free and completely free of suicidal thoughts. And here's a teaching point. This case illustrates how CB2 targeted therapy can address both pain and psychiatric symptoms without psychotropic complications of whole plant cannabis use. Now, at this point, we can broaden the scope beyond the primary conditions discussed. Substance use disorders. CB2 modulation modulates the reward pathways and reduces abuse-related effects, offering a novel approach to addiction treatment. As discussed in a previous lecture, CB2 agonist BCP has been found to be anti-addictive for all human and substance use disorders, including food, cognitive and impairment and memory. CB2 affects both memory types and hippocampal function. CB2 deletion impairs long-term memory and highlights its importance for cognitive processes. Female-specific effects on social memory and synaptic architecture are also observed. And then bipolar illnesses. CB2-related mechanisms modulate manic-like behaviors and depression. The neuroinflammatory pathways are implicated in mood regulation and dysregulation, and suggesting the CB2 target could stabilize the mood cycling. What happens to CB2 expression in different disease states? Well, during microbiome disturbances, dental decay, and low-level bacterial infections, LPS, lipopolysaccharide-induced inflammation, CB2 receptor transiently is downregulated in microglia under LPS stimulation. This suggests a context-specific therapeutic windows, but through the normal physiologic process of interferon stimulation, CB2 is upregulated, indicating its role in resolving inflammation. In neurodegeneration, CB2 expression increases in plaque-associated microglia and astrocytes in Alzheimer's as a part of a protective response to neuroinflammation. those CB2 receptors are begging for activation by endocannabinoids or phytocannabinoids to invoke corrective and anti-inflammatory and metabolic measures to resolve this insult. And then there's sex, age, specific differences, as in female specific age difference and age differences on synaptic architecture and social memory that highlight the importance of precision medicine approaches that account for biologic age and sex. Here are the 6 key neuroprotective pathways activated by CB2. Number 1, neurotransmitter regulation. Glutamate, dopamine, and epinephrine. These are all signaling molecules that are regulated by CB2. Oxidative stress. CB2 activation decreases reactive oxygen species and maintains mitochondrial homeostasis, critical for protecting neurons against damage. Synaptic function. CB2 prevents amyloid-induced dysfunction and preserves long-term potentiation essential for learning and memory. Neurogenesis. CB2 promotes adult hippocampal neurogenesis, supporting cognitive resilience and mood regulations. Blood-brain barrier integrity. It maintains tight junction proteins in the blood-brain barrier, preventing neuroinflammatory cell infiltration. And finally, it's a metabolic shift. CB2 stimulates mitogenesis, mitophagy, brown fat, and pro-resolving lipids, and energy balance. Now, these mechanisms work together to create a comprehensive neuroprotective environment. So this slide illustrates what CB2 activation is more than just an off switch for inflammation. It's a metabolic tuning knob that aligns cellular energy towards repair and resilience. Importantly, many psychiatric conditions have been identified with mitochondrial dysfunction, like depression, schizophrenia, bipolar disease, Parkinson, and Alzheimer's disease. So what role does CB2 activation play in metabolism? First off, there's mitochondrial stability. At the cellular level, CB2 activation stabilizes the mitochondrial membrane. This reduces the productions of reactive oxygen species and promotes ATP efficiency. We aren't just stopping damage, we're optimizing the cell's power plant through mitochondrial biogenesis. And then systemic sensitivity. In the periphery, CB2 modulation in adipose tissue reduces chronic inflammation and promotes the browning of white fat. This leads to improved insulin sensitivity and a more balanced systemic metabolic rate. After that, there's synergistic signaling. Note the convergence with metabolic signals like beta-hydroxybutyrate, and both CB2 and ketones inhibit NLRP3 inflammasomes and trigger NRF2 antioxidant pathways, creating a potent environment for neural repair. And finally, there's the receptor heteromerization. And here we see a complex of CB2 forming heteromeres with receptors like GPR55 and adenosine A2A receptors with a role in neuromodulation, cognitive function, and neuroinflammation. These complexes fine-tune how the cell membrane energy consumption and neuroprotection during inflammatory challenges. So the bottom line is a transition from an inefficient pro-inflammatory glycolic state to one characterized by optimized oxidative phosphorylation, or OXPHOS, and active homeostatic resolution. How does CB2 agonists compare to traditional antipsychotics and CB1 antagonists? So let's compare CB2 agonists versus current psychiatric medications. Regarding psychiatric side effects, responses are variable for conventional treatments, but they're low for CB2 agonists or non-existent. The psychotropic activity, that's high for antipsychotics and antidepressants, but there's none for CB2 agonists, as we've already shown. Abusive potential, moderate to high for standard drugs, but very, very low for CB2 agonists. Anti-inflammatory effects. It's limited with regard to these drugs, but it's very strong for CB2 agonists. And neuroprotection. limited effects of the standard pharmaceuticals, but strong effects for Parkinson's and Alzheimer's disease. And novel mechanisms. Traditionally, the standard medications are dealing with dopamine type 1 and type 2 antagonism with a great deal of intolerance, as well as serotonin modulation. This is versus the powerful anti-neuroinflammatory targeting of CB2 receptor activation. The key takeaway, CB2 agonists offer efficacy comparable to or exceeding current treatments while avoiding side effect profile. So I wanted to present another case about a treatment-resistant depression. A 69-year-old woman and a cannabis educator suffered from arthritis with hand pain and stiffness that kept her up at night, made her irritable, and severely restricted her activities. Combined with personal losses, she developed depression over a couple years that cannabis helped only temporarily. After taking 1/2 milliliter of beta-caryophylline, BCP+, all her symptoms immediately resolved. She demonstrated joy, enthusiasm, well-being. Her sleep improved to a full 7 to 8 hours, and she awoke refreshed each morning. Most importantly, she regained enthusiasm for her personal mission, teaching the benefits of plant medicine, and she continues to use BCP on a regular basis and has transformed her business into a very productive and prolific operation, offering advice and counseling with numerous podcasts with great exuberance. So the key teaching point here is that this demonstrates the rapid onset and comprehensive symptom relief possible with a CB2 receptor targeted therapy, addressing both pain and mood disorders simultaneously without psychotropic effects. When we talk about clinical viability of CB2 agonists, the real win is in the safety profile, especially when you track them up against traditional psychiatric meds that tend to hit brain with like a sledgehammer rather than a scalpel. One of the biggest hurdles in cannabinoid research is the rimonabant era, where CB1 antagonists cause severe psychiatric side effects like depression and even suicide. Because CB2 receptors are strategically located away from those specific CNS centers, we completely bypass those psychotropic risks. There's no euphoria, no cognitive fog, and zero addictive potential, which is a massive clinical advantage to CB2 receptor agonists. From a toxicologic standpoint, the data is incredibly clean. We haven't seen any organ toxicity, genotoxicity, or reproductive issues in preclinical models, which gives us very much a green light for human trials. In fact, early clinical findings are already confirming this. The side effects we do see are generally mild and transient, nothing like the weight gain, metabolic syndrome, or sedation that are often lead to patients to discontinue conventional antipsychotics or antidepressants. Ultimately, we're looking at a therapeutic class that is not only effective at resolving neuroinflammation, but is also exceptionally well tolerated for long-term use. Let's talk about the path forward with CB2 therapeutics. As we look towards the clinical horizon, the transition from bench to bedside centers on 4 strategic pillars. First, we're evaluating CB2 agonists as a monotherapy, specifically for treatment-resistant depression and anxiety. By targeting the neuroinflammatory root rather than just modulating neurotransmitters, we offer a new pathway for patients who haven't found relief through traditional SSRIs. However, we don't have to replace the current standard of care to be effective. As an adjunct therapy, these agonists can be paired with conventional antipsychotics. The goal here is synergy. Antipsychotic manage the acute symptoms, while CB2 modulation addresses the underlying systemic inflammation that often drives long-term disease progression. Moving even earlier into the timeline, there is a compelling case for prevention. If we can use CB2 modulation to intervene during or early in life stresses, we may be actually be able to prevent the microglial priming that leads to adult onset psychiatric disorders. Finally, from a regulatory standpoint, we have significant head start because we are often working with the natural agonists like beta-caryophylline, which already carries a strong safety profile and a GRAS, or generally regarded as safe approach under FDA standards, the pathway through the FDA is much cleaner. This allows us to expedite the approval process and get those protocols into the hands of clinicians and patients much faster than a standard synthetic drug. So to move CB2 therapies from theory to clinic, we must resolve the current problems of patient heterogeneity. Precision medicine is the mechanical bridge. Identifying specific biomarkers allows us to move beyond one size fits all and target those populations with the highest probability of response. With regard to neuroinflammation, we've got different types of scanning, PET scannings, functional MRI techniques that can provide direct visual neuroinflammatory state. In genetic markers, we can predict responses. With a patient's genetic blueprint, it can dictate the therapeutic ceiling on different agents that we might use. And through analysis, we can predict individual sensitivity to different substances. Imaging biomarkers, functional and structural mapping with functional MRIs and structural MRIs to track neuroanatomical markers such as hippocampal volume. These tools will allow us to visualize the physical impact of chronic neuroinflammation and resolution over time. And blood-based markers. And of course, frequent and comprehensive measures of systemic cytokines and their microRNAs could provide valuable resource for doing a liquid biopsy on neuroimmune health, offering a practical way to track treatment efficacy in a clinical setting. In conclusion, synthesizing these four categories, neuroinflammation, genetic, imaging, and blood-based, could enable a data-driven, tailored strategy that defines the future of precision medicine. So here's a general overview of the current drug development landscape. Now, there are natural agonists like beta-caryophylline. It offers a strong selective CB2 agonist from natural sources with anti-inflammatory and antioxidative properties. It's shown effectiveness in anxiety and depression and easily crosses the blood-brain barrier. But its current research level is at a very low state. Now, their current synthetic agonists are being used in preclinical research, are listed here. And the selective CB2 agonists show neuroprotection, and the HU308 shows anxiolytic effects. However, the RG7774, a novel oral bioavailable CB2 agonist, was discontinued in 2023 as a result of no particular benefit from these trials. And this is all too common with synthetic cannabinoids in isolated modes. And finally, the development status. There are at least 70 CB2 receptor agonists -1 that are in clinical development with a focus shifted towards highly selective agents over CB1 antagonists. So let me summarize the central messages from my presentation. First, the concept of a novel mechanism to treat psychiatric disorders. CB2 reduces neuroinflammation through microglial modulation, addressing the root cause of multiple psychiatric disorders rather than just managing symptoms. CB2 offers broad efficacy. Preclinical data shows that efficacy in depression, anxiety, psychosis, and suicide prevention without psychotropic effects, a unique therapeutic profile. Uniquely, CB2 could save lives immediately through suicide prevention. Altered CB2 and GPR55 expression in suicide victims identifies a novel protection strategy for at-risk populations, potentially transforming for high-risk patient populations. In addition, CB2 could be transformative to a broad range of behavioral disorders. It could revolutionize the treatment of neuroinflammation-related psychiatric disorders using precision medicine approaches with biomarkers and genetics. And personalized medicine with genetic and biomarker profiling can identify patients most likely to benefit, enabling tailored treatment strategies. Finally, CB2 agonists could be combined with existing treatments, enhancing efficacy and reducing the side effects of complex conditions. So in the broader endocannabinoid system framework, The goal of CB2 therapeutics is not to replace conventional psychiatry, but to complement it by addressing the neuroinflammatory foundations underlying many psychiatric disorders. So thank you for your attention on this important topic. Feel free to contact me with any questions by text or email.